And hello to everybody. I think it's probably various hours of the day right now. It's 3 o'clock in London. So good afternoon to anyone from Europe and good morning to those waking up in the US. Thank you for joining us to listen a little bit more about the criteria and the classification that came out last year that I know caused a lot of excitement and also a lot of concern and worry. So I just want to go through how did we get here, and more importantly, I think to focus on where we're going. So let us move on. I think it's good to look at a little bit of the history here. We had 20 years of neglect. The last time that the diagnostic criteria was published was 1997, and that was the Villefranche criteria. So that 20 years of neglect caused a lot of problems, not just for us patients trying to manage living with these problems, but also for the medical community. There was a real lack of research, there was a lack of collaboration, and so there wasn't the progression that you see in other comparable conditions. And then, of course, as we all know, that diagnostic criteria was published in March of last year and launched at the, because of an effort at the International Symposium that was held in New York. So I think everyone can relate to what they see on the screen here. The reasons why we did this are mainly because of the problems that everyone living with these conditions, whether it be any of the types of EDS or hypermobility spectrum disorders, which were newly described after this criteria, we face these issues. My doctor doesn't know what EDS. I can't work or live a normal life. And I think it's also it's a real impact on measuring what that normal is, and that creates its own pressures in itself. Nobody believes me. I mean, that is incredibly frustrating. It leads to more anxiety, more depression, and you kind of questioning what the hell is going on here? Is this in my head? Is this real? Why is no one understanding what I'm going through? That then leads to your family and friends not understanding, which means all of your support system around you is no longer there. And then when you finally get to a doctor, they don't believe the comorbidities. They just think it means you're a bit bendy or your skin might be stretchy. And then let's say you get to that doctor and they give you a diagnosis. You then can't get the management and care in your local area. And that, of course, then leads to you becoming much more sick and disabled. I'm sure at many points in your life, those that are listening have said or thought one of these things. And it's for these reasons and many others that we knew that something had to be done. So let's look at the timeline of how we got here. So in Ghent in 2012, the concept of an international consortium was introduced by Professor Francisca Malfe and Professor Anne de Pape. And they, for the first time, brought together world-leading experts into a room and discussed research and the need for there to be a revision of the criteria. The problem was that these were extremely busy clinicians and researchers who did not have the time to then make that a reality. Everyone knew what needed to be done, but there wasn't this overarching global organization to make sure it all happened. At the time, I was working at EDS UK and EDNF was in existence, and I was a director on the board of EDNF. And we met together in Glasgow at another international meeting, and we discussed how, although there were these efforts to bring together the change and to do the International Symposium in New York, there wasn't the sustainability to ensure that it happened every 2 years. And there was a resounding agreement that what was needed was an international organization. And so in 2016, EDS UK and EDNF funded the International Symposium, and also EDNF kind of shut its doors to what it once was and relaunched as the global Ehlers-Danlos Society. And I moved over and the executive director of that along with Shane Robinson. And we are now working towards our next international symposium, which is in Ghent this year in September. And the plan is to then have symposiums either every 2 or every 3 years, with the idea that even if it is every 3 years, there'll still be a scientific meeting every 2 years. And we're working out the best ways to do that at the moment. But as it stands, the next one is in Ghent in 2018. Okay, so what came of the Ehlers-Danlos Society more than anything was this amazing ability to create this international consortium on Ehlers-Danlos syndromes and related disorders. There were pockets of experts working all over the world, very, very hard, publishing papers, but there wasn't this kind of coming together. And we all know that together equals stronger in terms of medical professionals, patients, us. When we all unite and we're one voice, it's heard much clearer and louder. So we knew that we had to, above anything in our mission, facilitate the work of this consortium. And it's important to remember that we're just facilitating that. We are not controlling it or directing it in any way. We are just saying we are going to raise the funds and give you the sustainability you need to exist and do the work that we need to make our lives better. And so this is what the consortium looked like in 2015 when it launched. We had committees. We had the classical committee that was chaired by Dr. Claire Francomano. We had the hypermobile committee that was chaired by Dr. Frank Tinkle. We had the vascular committee that was chaired by Dr. Peter Byers. And we had the rare types committee that was chaired by Professor Francisca Malfe. And those chairs made up the steering committee, which is what I also sit on, representing the patient voice and also making sure the administrative side of everything is taken care of to make sure that they can do their jobs. This is what the working groups looked like. So we had a working group for all of the different comorbidities that we saw were important to get out those management and care guidelines at the time. We had the allergy and immunology, pain and psychological, the gastroenterology, autonomic and fatigue, neurology, the Baton score, physiotherapy, oral manifestations, and orthopedics. And again, they all fed back to the steering committee. And that amazing group of people, which at the time comprised of 96 medical professionals, were authors of what came to be the American Journal of Medical Genetics publication in March of last year. It was made up of 18 different papers. And as I've said before, and I don't want anyone to forget how hugely important this was. We waited 20 years for this paper to come out. We went from 6 to 13 types, and as you've probably seen in the news recently, just a year later we are already at 14 types. The concept of the hypermobility spectrum disorders was introduced, and we decided that it was for what we had in front of us, the evidence that we have, that we can still say that EDS as a whole, covering all the types, falls into about 1 in 5,000. So it's still a rare disease, rare condition. Now, the reality is that HSD is common. And the reality is that we know that there's probably people that are still not diagnosed. And when we find out more about the genetics of the hypermobile type, and we learn more and we do more research, I think we will find out that actually the hypermobile EDS is not rare, and it's a lot more prevalent than we can say. But right now, what we have and what we need is evidence to get the medical community to listen to us, take us seriously, and to create this tip of the iceberg that allows us to find what that gene is. At the moment, that's what we can say. And for the first time, we also printed management and care guidelines, and that had never, ever been done before. And so each of you can go and print these papers out for free on our website. There's a professional version and a lay version for you to read. Give them to your medical professionals, take them to your clinics and hospitals, and make people read, because there's nothing worse than people thinking what they know. To give you an idea as well about how popular and how many people are sitting up and listening to what this is, the morning that the publication came out, I was very privileged to do a webinar with Dr. Claire Francomano live at GBMC. And we had 18,500 views live, and we reached within a few hours nearly 111,000 people from all over the world. A few hours later, we did a press conference which live reached 27,000 people, and then after a few hours the reach had gone to nearly 70,000. And these are not just community members, these are not just professionals, these are big organizations that are sitting up and going, wow, look what they're doing, look at this progression. That afternoon I had an email from Genomics England who said, we're really impressed with what you've done and we'd like you to work with us to create the EDS panel as part of the 100,000 Genomes project. So the fact that EDS is part of that and how they got there is down to our consortium and the work we've done. So there's a lot that's come out, some that's obvious and some that's going on behind the scenes that perhaps people don't even realize. And why did we do this now? I remember seeing on Facebook a few people saying, why have you done this when we're finally people are understanding what EDS is? And that baffles me every time. I mean, I don't know about you, I've waited a really long time for my diagnosis. I see people every day still waiting a really long time. When we launched It's Our Time, the average, wait for diagnosis was 10 to 15 years. Why did we do this now? Because that's not good enough. Because we needed updated diagnostic criteria. We needed management and care guidelines so that it's not just expert hubs looking after us all, it's local services as well. And so that patients also have the information, education that they need so that they can go on and educate medical professionals as well. So obviously there's that, but we wanted to prevent this mis and underdiagnosis in the medical world. A lot of people are still not being diagnosed, and even with the rarer types, they're not getting their genetic testing, and we're seeing that people just aren't taking it seriously when we walk into a doctor's office. So we needed to stop that. But at the same time, there was this overdiagnosis happening in the patient world, and that's because, as I've said before, that great doctor that's free and has no waiting list, Dr. Google, is what's telling us all what we think could be wrong. And we can't be blamed for that, because if we haven't got access to anyone else, where are we going to turn? But we needed to stop this overdiagnosis in the patient world to gain credibility and respect from the medical world, so that people do the research, so that people want to go into it as a specialty, and so that people realize how much needs to go into the systemic needs that we all have living with this. We introduced hypermobility spectrum disorders so that we would allow all to be managed and validated. As I've said many times, and I really want everyone to take this home, hypermobile EDS is not worse than hypermobility spectrum disorders. The diagnostic criteria just look through a different lens. So you can have someone with hypermobile EDS that functions very well, works 9 to 5, Monday to Friday, maybe even an athlete, and they meet the criteria for hypermobile EDS. And you could have someone with HSD that doesn't meet the criteria, that's in a wheelchair, that's on TPN, that's really struggling. So get that out your head. It's not worse than, it's just different. We needed to really refine that criteria so that we could gain more understanding on the phenotype, so that we could work to finding what these genes are. And then what we think will happen is this big, pool of people that may be living with this HSD diagnosis, that it will be filtered down once we know more about the genes. What is critical for everyone to understand is it doesn't matter what it is called, it needs to be managed and validated. So if you are experiencing those comorbidities or those multisystemic issues, then your doctor needs to look after them. He doesn't need to worry, or she doesn't need to worry about what it's called and then stop there. Everything needs to be managed and validated. And that is the hope of introducing HSD, that will allow for that to become. So as well as the genetic sequencing that we are about to start, we needed better data for our registry, which we are launching imminently. The first global registry ever for EDS, to prove the prevalence. How many people are really living with this? Are there really more women than men? Are there more people in the Western world? How are we going to answer these questions? What is the average time to diagnosis? How many people have POTS and also mast cell? How many people have Chiari and also dysmotility? We need to answer these questions, and this registry is going to do that. And that registry then leads to more research. More research leads to better management. And one day, maybe some curative measures. So this really is, we waited 20 years to almost start again. And that's what we're doing. And I cannot tell you how much has happened in just that year. Since the 2 years that we've launched and the year since the publication, our organization has gone from strength to strength to strength. We're getting such credibility and recognition, and we really are getting more support to enable us to fulfill our mission and do this research. And it's incredibly, incredibly exciting. But let's not also forget why we did this. We did this now because people are dying. People are dying of the rarer types. They are, dropping dead of an aneurysm without ever knowing why, and they're being diagnosed post-mortem. People are dying with the hypermobile form of suicide and complications with surgery because people have left them and neglected them and not managed them in the way. Avoidable deaths that do not and should not be happening. That is why we did this now. And it might not be perfect for everyone, but it will lead us to a better place where we can all get the quality of life that we so desperately need and deserve. So people understandably had fears, and they turned to us with their fears, and they should, because we are there to try and keep your fears at bay and to assure you that although it's a any transition and change, it's bumpy, it's rocky, because you're moving to something new. But there is a lot of hope. But let's address some of those fears. So as I've alluded to already, let's kind of break these down. Is HSD a downgraded diagnosis? No, it's not. It's a different diagnosis, but that difference doesn't mean that you need different care. And we are doing everything we can as an organisation to actually improve our communications on this. We've learned a lot in the last year. We've learned what worked and we've learned what didn't. And we realise that actually HSD needs to be more understood, better communicated by not just the community and patients, but by doctors too. Because we did this not just to fill a gap, but to provide something that will ensure care and validation. So we're working on that. We heard you and we're doing better. And we hope that after Ghent, we'll be able to let you know what those changes will be and how we can give you tools to help you communicate that better as well to the people that are caring for you. We also got the fear here that why should the society decide what the criteria should be? Listen very carefully, because this is very important. We didn't. We had absolutely no involvement other than me passing on my patient experience as one of many patient experts in the consortium. That was independent. That was not the society speaking. That was me speaking as my patient experience. That really did not have any impact whatsoever on what was published as the criteria. People say, oh, Lara Bloom was involved. Well, yes, of course I was, because I was the person making sure that the work happened and that the meetings happened, that the things were funded. But I didn't get involved with what would be being published, because I think that is why we have this wonderful group of professionals that should be telling us, with patient experts, what these changes should be. We do not have any we do not interfere, we do not control in any way what the consortium do or work on. When it comes to the international symposiums, the medical board and the steering committee of the consortium decide what the agenda will be, what the focus will be, what the theme will be, and we just make sure that it can be funded, administrated, that the venue will be found, and that people will turn up. And that's what the society does for the consortium. It's the same with any research applications we have. When we have funding, we leave it to the medical board to decide those decisions, because that is why we, for the first time ever, have these brilliant minds that have come together that have said, we are totally committed to work together to make these changes. And that is what the society is here for, not to decide what the criteria is, but to make sure the criteria and the changes happen. So I really want that to be a take-home message, because it was very upsetting to read that kind of, you know, those accusations that come from fear, but also a little bit, you know, it's offensive almost, because it's like we're doing everything we can here to make everyone's lives better, and people are accusing us of saying it's because we've decided it's a rare disease because we've got rare disease funding. We have never ever had any rare disease funding. It was not in our interest whatsoever, actually, to say it was a rare disease. It would have been much better for us in all ways to say it was incredibly prevalent and that 1% of the population had it. But there's not the evidence for that. There's not the science for that. And that is what is the difference between the society. We have said we are really going on the science and the evidence, and we are being steered by what the publications are telling us, and that's very, very important. So we are here to support and make sure that the community understands everything. We're the bridge between the consortium and everyone else, and that is what we need to focus on. And everyone's support will only enable us to do our job better, to ensure that continues. People also pointed out the limitations of the Baton score. More joints are needed. Absolutely, we agree, and so does the group. And you'll see in a couple of slides' time, we actually realised that perhaps it won't always be the Baton score that's used, and so we actually changed the name of that working group to measuring joint hypermobility. And that group are working on ways, but I think it's very important to understand that you can't just introduce a joint and not fully understand how you're going to measure that joint, and make sure that it can be measured in the same way no matter where you are in the world and no matter what specialist is looking after you. And that's why it takes time to introduce these other joints. Why didn't we ask patients? We did. There is a patient expert on every single working group and on every single committee. Why were there no comorbidities in the criteria? There were no comorbidities because we didn't have enough evidence at the time to prove the causation between the two. Now, We are revising things, we're looking at things, we're assessing things leading up to the Ghent Symposium. And I imagine that there may be updates in the next few years, maybe even sooner, into the diagnostic criteria. But that is the beauty of having this there now, that we don't have to wait 20 years. When there is sufficient evidence and enough evidence to say what we can put in the criteria, we can make those changes very quickly. So keep an eye out there. The thing that is important is when people say that, you just need to look at the 17 other papers that are all about the comorbidities. So anyone that is treating anyone with EDS or HSD, you have to look through the lens of those other comorbidities. You have to think about those as well. And that is why the whole thing was one publication. So I think it's important to acknowledge that as well. The comorbidities were not left behind. In fact, for the first time ever, they were spotlighted. Will I lose my diagnosis? No. No one is going to take your diagnosis away from you. If you go to a new clinic and you ask to be re-diagnosed through the new criteria, then yes, maybe, but that's your choice. No one's going to enforce anything of you. If you take part in a research project where it's important to fulfill the new criteria, then perhaps, but you can also ask not to be told, and it's whatever you take away from that. No one is enforcing anything, but going forward, if you haven't been diagnosed previously, then it will be done using the new criteria. And I addressed this earlier. EDS was just getting attention. Why make it worse? I feel very, very strongly, and I feel very, very proud of the work that we have done, that I can say, I think with conviction, that we have not made anything worse. And I think it's important to remember that today is only the beginning. It's not the end. We had to start again. We had to go backwards to go forwards. And there are a lot of hopes to think of. Let's not look back. Let's not look past. Let's look forward to a brighter future with a lot more hope and a lot more possibility for all of us to get what we need. So let's look at some of the things that we can be hopeful for and go off on a positive note, because I can't tell you how much there is to be positive about. We have this incredible consortium, which is now made up of 140 people from all over the world, from all different disciplines. And they have meetings every 2 years, which means there are regular updates. So we do not need to worry anymore that the work is being done. It is being done. It will be published. It is being more and more recognized. Every conference I go to, every meeting I go to, every doctor I speak to who says there is so much more interest, respect, and understanding about this condition since the publication. Things have also shifted in the structure of the consortium. So the committees going forward still have all the same chairs, but we've introduced the hypermobile EDS and HSD committee because we recognise that both need to be focused on within that group. The working groups, as you can see, has also grown and expanded. We realised that we shouldn't be clubbing things like pain, psychological, and gastro and neurology together, so we have expanded it. We've introduced a pain group all on its own, a pelvic floor group all on its own, psychological group all on its own. And we've also introduced the pediatric group and the skin group. And as I said, we have now changed the Baton group to measuring joint hypermobility. And we are funding lots of research. We are working with EDS UK to fund a project looking into nutrition and EDS. We have funded microgrants program with $20,000, and we are going to be announcing the people that have been awarded to and details of what they're going to be doing in May. And we are also going to be announcing further funding over 2018 for more research to be done. It was at the heart of our mission, and it's a real change in direction for us. And I think the first time really ever that there has been this focused energy into research in the Ehlers-Danlos syndromes and related disorders. And let's not forget this incredible, generous donation that was given to us at the end of last year for $1 million. And we announced that in February of this year. And it's going to be taking EDS research to new heights. And it really is. We're going for our moon landing here. And that is to find what the genetic markers are within the hypermobile EDS. And I think we're going to learn so much from this project, and we're going to be announcing ways that people can be involved and take part in that sequencing. So watch this space. We formed, because of PCORI, a grant that was funded to us, the first EDS Comorbidity Coalition. We brought together partners, patient experts, lots of different stakeholders, professionals, focusing on the relationship between all these comorbidities and what research can be done to improve awareness and care. And so that's really developing. We've had one face-to-face meeting. We've got our next one in a few weeks, and then one in August. And that work will go on, and that will be a long-lasting group of people that are really focused and energized to proving, if we can, what these causations are and what the relationships are, and more importantly, how we can make them better. So how can you help? How can you take responsibility? Well, there's lots of ways. For a start, could everybody please use the new terminology? I still have people emailing me saying, I have type 4 and type 3, I have type 1 and type 2. They don't exist anymore. Actually, people don't realize that numerical descriptors went out in 1997. So it's been a really long time since they have been in use, but yet still people, even professionals, use them. So it's gone from the Ehlers-Danlos syndrome to Ehlers-Danlos syndromes. There's 14 of them. Let's not forget that. It's not just about hypermobile EDS. There are 14 Ehlers-Danlos syndromes. It's, instead of hypermobility, it's hypermobile. We wanted to clarify that and get consistency for people using that all over the world. And when people are shortening it, we're asking you to use the small letters to describe it with the capital EDS. Joint hypermobility syndrome, benign hypermobility syndrome no longer exists. And instead, we have the newly described hypermobility spectrum disorders. And as I said, the numerical descriptors are no longer. And there's also the understanding that you can't really have more than one type. If you do, you're publishable. It's just incredibly rare. What you can have is one type with symptoms of the other type, but that does not mean that you have more than one type, or if it's the rarer types, more than one mutation. It's not scientifically impossible, but it's so rare you would make it into a published paper. And then the other thing that's key is dissemination, education, but most importantly, re-education. There is nothing worse and more damaging than a doctor who thinks they know what EDS is, who thinks it's just stretchy skin and bendy joints, who thinks that you can just go off and live life with no issues. We need to re-educate that doctor. We need to educate the new students that are coming through that could help the future generations. And we need to disseminate this information to family, friends, professionals, clinics, labs, everyone we can. And the great news is it is all for free to download on our website. Leaflets, all the papers, lay versions, and there's going to be more and more and more as we go on and as we grow. So please utilize that, print things out. We have awareness packs, we have PowerPoint presentations you can give to medical students and to raise money and funds and awareness for us. So use all these tools. You can find them all in the Get Involved section on our website. So I will say thank you and acknowledge my co-executive director Shane Robinson and all the staff at the Society, all my colleagues in the International Consortium, the Ehlers-Danlos Society Main and Medical Board, and our amazing community, you and all of your families. Thank you from the bottom of my heart for your support and the strength to go on when sometimes it feels impossible to. I truly thank you. And I will now open up to any questions and show you my face. Hello, everybody. So Jess, let's have a look. Can I see these questions? Let me see. I can't see any questions. So Jess, could you help me out with the questions, please?
Absolutely. Everyone, please go ahead and type your questions, and I will read them up to Lara. The first question we have is from Rosemary. It says, if you were the first in your family to have EDS, why do you always need history to fall into the categories?
Family history is definitely an area we need to improve on when it comes to the criteria. It's something that comes up a lot. I think because what we're saying is that this is a genetic condition, family history really helps to paint that picture. But yes, if you are the first in the family, then that's 1 point down on the criteria. And I think it's a weakness in it that we have noted and that people are looking into. So watch this space, I guess. But there are other ways that you fulfill the criteria, and that is just one of the things on the checklist.
We actually don't have other questions right now, so please get your questions in. We have lots of time to answer them. It seems like with the other webinars, once we started answering questions, lots more came in. So get your questions in, everyone.
Or not.
Or not, you know.
I'm very happy to answer any questions people have.
Okay. Does EDS affect your teeth?
Well, yes, it does. We obviously in different types it affects it in different ways. So, are you asking? I am assuming in hypermobile EDS, does it affect your teeth? Yes, it can do. Something that is also very much affected is TMJ, the jaw joint, which can then cause tooth pain. There can also be a weakness in the gums. But it's certainly, we have the oral manifestations group for a reason. There is definite involvement. There have been a few papers published on it, but it's definitely an area that needs more research. But yes, is the short answer. The detail of it is different in each type and different on each person as well.
What age is it recommended to get a child diagnosed?
Well, I think it's important to get people diagnosed when they're symptomatic. So often parents who have it that see small signs in their children think it's important to get diagnosed. And I think it's important to get diagnosed when those symptoms are becoming problematic. So that's the age, really. It's not that there is a set age where everyone should be diagnosed. Certainly the earlier that you are doing preventable measures, then the better the outcome is going to be when anyone is older. We know that when hormones kick in, certainly for women, that things become much worse. And sometimes they don't. So it really is very different. You have to remember we have a big spectrum here of the way that this can present. But I would say, you know, whether it's 3, 13 or 30, when those symptoms become life impacting and that they're causing issues, that's when you should seek a diagnosis. I don't think it should just be, oh, that I see a bit of hypermobility and I have it. I wouldn't panic about getting that diagnosis. I think also, you know, it's knowing the tools that you need to manage it. So if you know that your child is hypermobile, you need to do muscle strengthening exercise with them. You need to respect it. So probably avoiding things like impact sports and, you know, overly heavy gymnastics and things like that. And so doing the right things, swimming, having a good diet, getting lots of sleep, having lots of water and fluids, and doing the things that are relevant to that, what that diagnosis would do, you kind of should be doing anyway to give them that chance of being less symptomatic. And it's when other things kick in, like more severe autonomic symptoms or mast cell symptoms, that then it's time to go and seek that intervention. That would be my opinion.
Thank you. We've got a lot more questions coming in now, so thank you all for those questions. Definitely keep them coming. Is it possible for 2 people in a family to have a different type? This person, her sister was diagnosed with hypermobile, and she has had a diagnosis of classical.
Was it a genetic confirmed test of classical?
I cannot see that based on the question.
So I'll answer either way. So if it's a genetic confirmed test, I would say that it would be worth both siblings having a genetic test to rule out that maybe they're both classical and that one just has more symptoms that's thought to be within the hypermobile type. And if it's not a genetic test, then there's a chance that they are both hypermobile and one of the siblings just has more classical symptoms. As I said, scientifically, I guess it's possible that they have 2 different mutations, but of course we don't know what the hypermobile mutation is yet. So it's very hard to say. I would say it's more likely that there is a misdiagnosis of either one of them rather than 2 different types. That's that's without knowing them or seeing them and also not being a medical professional. So that's just my experience. So that's what I'd assume.
Is there any evidence for gross motor delay as an indicator of EDS?
Not enough evidence, but there's certainly anecdotal evidence. And again, an area that needs more research.
How do you educate doctors about the new criteria when they aren't open to this? This includes geneticists.
Patience, resilience. You have to keep pushing it under their nose. And I think time heals everything. So a lot of the professionals are resistant to the new criteria because they have a preconceived notion of what they think EDS is and what an EDS patient is. And I think as we publish more, as we show more evidence of things, that will heal itself. And it goes back, the reason we're in this state is because of that 20 years of neglect that we had, whether there was that time for those kind of feelings and those thoughts to even breed and take root. And I think we're only a year in. I think people need to remember that, and it's going to take a lot longer to stamp out those thoughts, stamp out that ignorance and people thinking that they're not going to be open to the changes, and just say, well, here it is, it's free, there's the papers, you can read it, and keep taking it on every visit that you go to. And also, if need be, you need to, I know it's very hard and it's different in every country, but you seek another doctor, seek another opinion, and just keep trying to educate as much as possible.
I have one question that I can answer real quick. Do you have a neurological subgroup in addition to psychological? Yes, we do have a neurological subgroup.
And you can find out, if you go onto our website and you go to About Us, you'll see International Consortium, and within that you'll see all of the working groups and committees, and you'll see every single member and their bio and picture. So this is all very much public information for you to all go and see.
Here's two questions that are related. One is, what type of doctor would you suggest to start with to be diagnosed? And the other is, what kind of doctor would be good to follow a person with EDS?
The question is, it depends where you live. So in the UK, a lot of people are diagnosed by rheumatologists, for example, and less with geneticists, whereas in the US, it's more geneticists than rheumatologists. And I think the question is what we hope to get to is a point where it doesn't matter what doctor you go to, they're all able to use the diagnostic checklist and diagnose. And then there is that care and management that comes from the different disciplines. The dream is to create multidisciplinary teams globally comprised of all the different disciplines that come under EDS: neurology, gastroenterology, psychology, physiotherapy, all of these things, and it being the time where we have a genetic marker for all the different types, and you would go to a geneticist to find out what type, and then you go to your MDT team to manage it. That's the dream. That's what we're working towards. And I think we've got much further along that dream than we thought we had after just a year or two. So that's what we're working to. That's the perfect model, and we're just trying to do what we can to get to that.
This is from Sharon, and I think Lara's going to like this question. I read that May is EDS Awareness Month. I would like to present information to my local providers suggesting that when they do children's physicals to screen for EDS. Is there information that I can give the doctors?
There's not screening tools as such, as in we've got the diagnostic checklist, which you can print for free on our website. We've got the physiotherapy paper that you can print for free on our website. And we've got a awareness toolkit, which has a PowerPoint presentation in it, which talks about EDS, post criteria, gives you all the information that you need to know. But you can't, it's hard to then enforce a screening amongst a group because it's not yet international standard to do that. So you can certainly give them the tools they need to do that screening, and you can give them the tools to educate them about the new criteria and promote that early diagnosis is beneficial. But it's very hard to screen because, it's a question that no one has the answers to. Are you looking for instability or are you looking for hypermobility? And I think instability is where that key comes in, where it could be something like HSD or hypermobile EDS. Because if you're screening for hypermobility in children, you're going to pretty much see it in every child. So it's not clear cut and it's not straightforward, but certainly the tools to raise awareness about the new criteria and all the comorbidities and a PowerPoint presentation is all downloadable on our site.
Here's an kind of a long one. My family has a history of 4 generations of hypermobility, and we are all undiagnosed. My 13-year-old son is tall and very slender, but 2 years ago when I took him to the doctor with problems with pain in his shins and his feet, he was considered just overweight. Because he was overweight, doctors said her experience showed EDS patients to be tall, skinny, with GI issues, and so she didn't think my son could have EDS. Ultimately, can an overweight person have EDS?
Yes. Anyone can have EDS. Tall, short, fat, thin, black, white, brown. You see in clinics what you think is the standard kind of vision of someone with EDS: tall, skinny, female, white. You just need to go to one of our conferences to see that's not the case. And it's just lack of education and awareness, and I think any doctor that actually uses that as a reason to not diagnose is shocking. But we do see it, we hear of it, and we hope that with the right education, and if they read these papers, they would see that yes, there's a prevalence amongst a certain group, but that is not an eliminating factor.
Is there recommended resources to understand the link between swallowing difficulties, spinal issues, neck issues in EDS, where rheumatology, GI, ENT, and neuro intersect? Thank you very much.
So if you look at the GI paper, they address swallowing, and if you look at the neurology paper, they address all the issues with the neck, and they are, they're looking at all of those issues through the lens of EDS. So that's where I would start. And there's a lay paper and a professional paper for each of those.
I believe the TMJ paper also has some of that information.
Yeah, the TMJ also with swallowing, you're right, and with neck pain. So the oral manifestations paper as well.
What do you say to the doctor who doesn't understand why diagnosis of EDS is important because there's no treatment for EDS?
There's no cure for EDS, but there is management. And I think there is a lot that can be done. The correct physical therapy, diet, strengthening your core. And also, critically, which is massively, massively neglected in every country, is the psychological support. You can't treat a chronic physical problem without addressing how your mind copes with that. And I think that that's something that, in itself, CBT and mindfulness and approaches that can help, Alexander technique, all these things that engage the mind with the body is, to me, as close to treatment as we're going to get, and, for the foreseeable. And so when a doctor says that, you can just remind them of all of the different tools that there are that are discussed. Again, go back to the papers. They are discussed in these papers, in the diet, in the GI, in the physical therapy, in the physio. There are things that we can all do to make living with this a lot easier and better, and that would avoid often splinting and being in a wheelchair and being weak and debilitated because of deconditioning, and that incurs more pain, more fatigue. It's a vicious. We're constantly chasing our tails with EDS because one comorbidity can cause another comorbidity, and react to another. It's just being chased constantly, and there are ways and things you can do that can help you run faster. And I think that is what you need to let doctors know. That's why it's important. But also, it's really important to finally know that there's a reason for why you felt like you have all these years, and to be validated and to be understood, and to not think it's all in your mind. And I think doctors don't realize how incredibly important that is.
Do you know of any good research on the connection between EDS and vision or hearing issues? I'm struggling to get treatment covered because medical professionals aren't understanding the link, even though it's obvious to me because there's collagen in the eyes and ears.
Trying to think of, we just did a survey on the eye and EDS, didn't we? But I'm trying to think, that wasn't so much your standard kind of eye issues. There's again a lot of hearing issues, eye issues, the peripheral issues that aren't discussed a lot, that you see anecdotally. There's not much research out there, and there needs to be more. But I guess when you get a research pot and you've got the huge things in front of you, like POTS and mast cell, that are so prevalent. Unfortunately, the other areas again get neglected, and it's only when we increase that research pot that we can start to answer these other questions that I agree are very important. I myself, I'm 40 decibels deaf in my right ear. Jess, I know, I'm sure you won't mind me saying, has hearing problems. You know, that's 2 people in a group of 7 staff members of the EDS that have hearing problems. There must be something going on there to cause that, but we don't quite understand. Sometimes it's something that has nothing to do with EDS, and sometimes it might actually be part of the puzzle. But again, most of my answers are, unfortunately, more research needed.
Why has it been so hard to find the gene for hypermobile EDS?
I think because we're not looking for one gene, we're looking for lots. And I think the other reason is because the phenotyping hasn't been strict enough. So that's why we made the criteria stricter, so that we could create a tip of an iceberg. Because if you're then looking at the whole iceberg, you're never going to find it. But if you've got a tip, then it's going to make it a lot more realistic and a lot easier. So that, I hope what we've done is going to lead us to finding that gene, which will lead us to finding more genes. And it's not going to be one gene, it's going to be lots. And it might end up that it's actually lots of rarer types, and there ends up being 40 or 50 types of EDS rather than just 2 or 3. And we're not going to know until we start doing those studies.
This one is from Hillary. Says, "Hi Lara, thanks so much for all you do. Relatively new with the diagnosis of classical EDS and going to clinic soon. Is there any instance where genetic testing isn't really needed? No living family members with any of these issues, only deceased mother who had many issues but passed."
At this stage, we don't recommend those that kind of have the symptoms of hypermobile EDS or HSD to get genetic testing, because we don't know the genes, so it's not recommended. It's only when a rarer type is suspected that we advise genetic testing. So I would say no.
Just for clarification, she did say she was recently diagnosed with classical.
Oh, classical. Sorry, I didn't hear that bit. And again, so she was clinically diagnosed with having classical. So I think if the genetic test is an option and you want clarity, then yes, I would do it, because it's there and you know the mutation. But again, it goes back to the management. As long as things are being managed and you're being taken seriously and you're being treated, then that's what's ultimately important. That's why people tend to have the genetic testing. That genetic answer isn't going to change how you're managed. It's just going to give a bit of clarity.
In a family where there are multiple genetically confirmed connective tissue disorders, what do you do when the EDS gene test results were inconclusive? This geneticist said, clinically, I was presenting as both hypermobile and classical.
So there were multiple connective tissue. Well, then, I mean, and I may not be understanding, it would be that it would, for now, hypermobile EDS or HSD until we know more about the genetics. If they're inconclusive with the mutations that we know, then at this stage we can't. You wouldn't be able to give more detail. So I guess right now it would be, if they think it's classical based on presentation, then, you know, again, it goes back to the fact that it doesn't really matter. It just matters that you're being managed and cared for. So hopefully when we know more, and when genetic testing is more of an option, then that might be the time when the genetics will lead to more discovery. But right now, I would say it's probably would be a go-to HSD or hypermobile EDS diagnosis.
We have a doctor that believes that hypermobile EDS does not cause pain. He believes once a joint dislocates, it will only hurt the first or second time because the body just gets used to it. Could this be true?
I'd say he should have EDS for the day and then answer his own question. I would say it's ridiculous, it's ignorant, and he just needs to read even 1 or 2 papers to realise how false that is. Worrying that there's people out there that think that.
When genes that cause hypermobile EDS are being studied, will those be available to those of us who have whole exome testing results?
So if you've previously had a whole exome sequence and we then find out what they are, yeah, we will release when we know things so that you could look back, I guess, that in the same way that all of the 14 types with the mutation is published, so it's not anything that would be hidden.
When will there be more announcements about the conferences in Australia this year?
June we open registration and we'll release the schedule.
Where are the papers on the resource link? Where are the papers that you're referring to on the website?
They're in various places. So they are under professionals. You can get to them there, and they're all, whatever drop down you find them on. So they're under About EDS, and they're also under the professionals, and they're titled the International Classification EDS 2017, I think, something like that. But they're in various places on our site.
What is, there's a question in quotation marks about what this term means. What is frank joint instability?
Frank?
Yes.
I'm not aware of that. Are you, Jess?
No, not specifically that one.
No. Sorry.
Why wasn't HSD named as a type of EDS?
Because there wasn't, it was kind of looked through the lens of a true connective tissue condition, and that having such wide range of symptoms on for example, on the Brighton criteria, it just wasn't fulfilling what truly was seen as Ehlers-Danlos, and making it more about the connective tissue and more syndromic is what's enabling us to make it that kind of tip of the iceberg. So HSD is treated in the same way as hypermobile EDS. As you can see from our organization, we treat it exactly the same way. We serve the community in exactly the same way. But we did it so that out of that HSD pot, we can pull more of the types of EDS, because I think that's long-term what will happen. I think what's currently is the cause is it's probably a group of people that we have yet to be able to say more on what type they have, because we don't yet know the genetics behind it, rather than them all being one type. So I don't think it would have made sense to just make HSD one type, because I think when you start phenotyping people and breaking it down, which we can do with the registry, you'll see a clearer picture, and then we'll be able to hopefully sort people better. And we may not, as much as the goal and the aim is to come up with genes from this, another success that might come out of it is that it's not genes. And I know that sounds scary, but then we can then look at other things and other markers, and not finding things would be disappointing, but it would tell us as much as if we did find other genes. And it would just mean we need to ask the question in a different way. But I think it would have been a mistake to just, I think Dr. Alan Hakim always says, are you a lumper or a splitter? And I think it makes more sense for science and for our care to be a splitter than a lumper. And I think there's been a lot of lumping that had happened historically because of this lack of updating. And I think we need to avoid that to be able to progress. We were stuck. We need to unstick ourselves.
Is it recommended to have a POTS or dysautonomia test after being diagnosed with hypermobile EDS?
If you're symptomatic, then yes. I don't think any test should be done to exclude or prevention. It's if you're symptomatic with something, then you should get it managed and tested for. I don't think you should never kind of look at the list of what EDS could cause and wait for it to happen, because there are ways that there are certainly many examples where people don't have all the different comorbidities, don't have all the symptoms, and I think the best way to avoid having those symptoms is to keep as mobile and active and strong as possible, and to be doing all the other holistic things that assist with that, such as what I've said: diet, fluid, sleep, and that they may never come, and that doesn't mean again that means it's less than or not hypermobile EDS or not HSD. It's just a different, part of the spectrum.
Is there any research into the flare aspect of the symptoms?
Layer aspect.
Flare, as in sometimes you have flares of symptoms.
Flare. So say the question again.
Is there any research into that aspect of EDS?
So what causes flare-ups, such as hormones, age, infection, illness? Not really, other than the understanding that there are flares, and it would be very, very interesting to research more into what causes them. So again, more research needed, and it's something that's come up a lot talking in the Comorbidity Coalition.
What is best for pain in the spine with EDS? No pain meds work now, since I've been on them for 10 years or more.
It's very hard for me to say without knowing what the cause of the pain is, and also I'm not a medical professional, so all I can say from experience, what helps me with pain is trying to keep as strong as possible whilst respecting the problem. As many have heard, I've got a tear in my glute, labeled tear in my right hip, and I'm having physiotherapy for that, and I'm going to the gym 4 times a week to make all the muscles around it as strong as possible. And when I'm doing that regularly, the difference is huge in my pain, and the injury hasn't changed, but my body's ability to cope with it has. And I think I can't stress enough how much strength and muscle tone, and it takes a really long time to build that strength, more than your average person. When EDS for some reason makes muscle building even harder and takes even longer, but it really can be hugely life-changing. It takes time, takes persistence, takes strength mentally and physically to keep going, but it really can make a difference, and it may help your back pain, but I don't know what's causing your back pain, so that would be something you need to speak to a medical professional about.
Since there is a lack of published research on HSD because it's so new, in terms of management, should we consider hypermobile EDS research in line with HSD?
Absolutely, it's the same management and care. All the management and care guidelines in the publication were for HSD and hypermobile EDS.
This is going to be the last question. We're about out of time here. Are there specific lung conditions that are specific to EDS? Also, quinolone antibiotics aside, are there any other antibiotics that can cause collagen breakdown?
Not that I'm aware of. I know that within mast cell and immunology there can be lung problems. I don't think, and again, I'm not an expert in this, someone like Anne Maitland would be better off answering this, and she has got a webinar that she's doing for us in a few months. But certainly lung involvement can be there, but specific is not something that I'm aware of.
Thank you, Lara. And that is our last question of the day. It is now 11. Thank you all for joining us. Our next webinar will be next week. That is Wednesday, May the 2nd. It will be led by Ellen Linnick-Smith, and the topic is an evaluation of the use of cannabis in EDS with chronic pain. I hope to see you all there. You should see on our website and on our social media a sign-up link soon for that one. Thanks, you all.
Everyone. Have a great day wherever you are.